Very good morning and happy Basant Panchami to all of you. So this is the fourth online class under the banner of UP-AROI chapter. For moderation, I am inviting Dr. Ashutosh Mukherjee, who is the head of Radiation Oncology, HBCH, which is affiliated to TMH. So Dr. Ashutosh, kindly start.
Good morning, Dr. Surbi. It's a pleasure to be participating in this teaching program, and I'm very happy again to be working with you, ma'am, after all these years. For today's talk, I would invite Dr. Indu Bansal, with whom I had worked a long time back, and again, it's a pleasure meeting you, Dr. Indu, again. So, Dr. Indu would be talking on contouring and planning of gliomas. And we will take questions in the end. And if anyone does have questions, please put them in the chat box. We will try and address all your questions towards the end. Thank you. So, I'll invite Dr. Indu to please start.
Thank you so much. So good morning, everyone. And it's a real pleasure to be invited by UP-AROI to give a presentation on contouring of gliomas. So let me be honest that I would be concentrating more on contouring. And I've mainly focused my talk on GBM because there is not much controversy in the contouring of low-grade gliomas. And there are a lot of new structures which have come up, which as a radiation oncologist, we must know so that we can plan our patients well. And this session is going to help you not just in contouring of GBMs, but any brain tumor in general. So I'm working at Narayana Super Speciality Hospital as Director of Radiation Oncology. Now, we know that whenever we have to contour any case of a brain tumor, we have to first optimally select the MRI sequences. Because if you don't select your MRI sequences well, and you don't know your anatomy well and the patterns of spread of a tumor, then you will always do a lot of mistakes. So this is so for GBM. What is the ideal time to do MRI, and what type of images you should choose? So ideally, they say that MRI within 48 hours should be taken because otherwise there is a lot of peritumoral edema. But in GBM, what happens if you do it within 48 hours and the patient is treated, say 3 to 4 weeks later, then there is a lot of shifting of brain tissue and there is some risk of regrowth of the tumor as well. So ideally, for GBM, your MRI scan should be within 2 weeks at least. So the target delineation should be on contrast enhanced T1, T2 and flare sequences. And there, as per the guidelines, perfusion, spectroscopy and diffusion weighted images, they are not yet into guidelines, but sometimes we have to look into them to properly delineate the tumor. And it is very important that you should see your perfusion spectro images as well. So now a lot of data is coming up which says that if you use diffusion contrast enhanced MRI, then, and there are large hyperperfused tumor pre-treatment, then it is associated with inferior survival and progression-free survival. Coming to PET, FDG PET is not much useful, but in re-radiation settings, sometimes we have to use a PET to delineate the areas which are recurrent versus radiation necrosis. And 11-choline PET has been shown that in 75% patients may have abnormal uptake beyond the enhancing tumor volumes. And in fact, 50% may have tumor cells even beyond the T2 hyperintensity. But 11C PET is not available in most of the centers. So first, we should understand the basics of MRI because this is very, very important. We should know what is T1, what is T2, and what is flare. So if you see a T1 weighted image, then the CSF would appear dark, your white matter would be light, and the cortex would be gray. You will be able to appreciate cortex in another sequence, but if you can see this is the cortex. So cortex would be gray, and the fat within the bone marrow would be bright. While in a T2 weighted sequence, the CSF would be bright, the white matter would be dark gray, and the cortex, if you can see here, cortex would be light gray. This is the cortex, and this is the fat within the bone marrow, which is light. The flare sequence is which shows CSF as dark, but white matter would also be dark. So how do you differentiate between a T1 weighted and a FLAIR image? That CSF would be dark in both, but in FLAIR, the white matter would be dark gray, the cortex would be light gray, and the fat would be light as compared to a very dark signal on a T1 weighted image. So this is what you can see. So this is a T1 weighted image without contrast. And if this is a T1 weighted image with contrast, where you would see a bright signal in the blood vessels. And this is a FLAIR image. And you can see if you have to differentiate between the tumor and an infarct, you can differentiate that only in a diffusion weighted image. So I was talking about white matter tracts because diffusion tensor imaging, sometimes we see that in spite of delineating everything well, the patient comes back with a recurrence, and then you keep on thinking, what did we do wrong? So a lot of data is emerging that which says that tumor cells, they spread along the white matter tracts. So if you see a diffusion tensor imaging, then you would see that this red signal is basically the right to left signals, white matter tracts, while the green is from superior to inferior and blue is from foot to head. So in this image, you can see that this is the red area which shows the crossing tracts at the midline in the corpus callosum area. And here you can see descending tracts from thalamus into the brainstem. And here you can see crossing tracts from the anterior and the posterior commissures. Now coming to spine MRI. In the spine MRI, in a T1 weighted image, the CSF appears dark, the muscle is gray, spinal cord is gray, and the fat appears bright. And there in the air in the pharynx would be very dark. While in a T2 weighted image, you would see CSF would be bright, the muscle would be dark gray, spinal cord would be light gray, if you can see this here. So, sorry, spinal cord would be light gray and the fat would be light. Now, this is a coronal sequence. We must always remember that whenever you are doing any planning, you should not just look into the axial images, but looking into the coronal and sagittal images is also very, very important. If you see this image, then you would be able to appreciate the superior sagittal sinus. When we do contouring of meningiomas, we need to know what is a superior sagittal sinus. And this please remember this picture in mind, because I'm going to talk about this corpus callosum. So this is the corpus callosum. If you can see, this is the fornix, and this is the thalamus. This is the midbrain, the pons, the medulla. This is the foramen magnum. This is the anterior cerebellum, and this is the posterior cerebellum. So posterior cerebellum has been found to be associated with cognition. And in fact, it has been seen that in patients, even with head and neck cancer, which get a higher dose to the posterior cerebellum, they may have poor cognition. So, and you can see here, this is, if you see the corpus callosum, this is the genu of the corpus callosum, and now some data is emerging on sparing the genu to prevent the cognitive function. And this is the body, and this is the splenium. And where the splenium ends here would be the pineal gland. Now, if you see this axial image, this is the frontal sinus, this is the genu of the corpus callosum. Just lateral to the lateral ventricles, here we see the caudate nucleus, and this is the falx. We have to understand where is the falx, because we have to trim our structures or contouring at the falx cerebri. This is the splenium, and this is the choroid plexus. Now, why do we need to understand the effect of radiation on neural tissues? Because the preclinical studies have shown that radiation leads to depopulation of the oligodendroglial cells. And also there is endothelial cell depopulation, which leads to microglial cell activation. So all these parameters, they lead to white matter necrosis. And if there is early effects, neuroinflammation, then also there is stunted white matter connectivity, which all lead to late effects of neurocognitive deficits, and there are complex interactions of many cell types. And now with advancements in technology and newer medicines, our patients are living longer, so we have to really focus on neurocognitive deficits. Now, what effects radiation will cause would also depend on the area of the brain that you are treating. So suppose if a tumor is in the frontal bone, and then there would be changes in the personality and interact, and there would be uncoordinated walking or weakness of one side of the body, loss of smell or occasional speech difficulties. If it's a temporal lobe tumor, then it is associated with a patient with present more with seizures, fear, intense familiarity. There will be strange smells or blackouts, speech difficulties, and memory problems. In a patient with a brainstem tumor, there would be unsteadiness, uncoordinated walk, facial weakness, one-sided smile or drooping of the eyelids, double vision, difficulty in speaking or swallowing. While in a parietal lobe tumor, there would be problems in speech and understanding. The patient will have difficulties in writing, reading, calculations, and there would be problems in numbness or weakness on one side of the body. With the occipital lobe, there would be loss of vision on one side. And we all know that with cerebellum, there is lack of coordination in walking and speech, unsteadiness, flickering of the involuntary movement of eyes, vomiting, and neck stiffness. So now coming to the guidelines. So there are few papers which we have to understand, which are very, very important. And everyone should go through these papers, not just once, but at least 5-10 times. Then only you will understand what they're going to say. So there was this paper, Eastro-Ekrop Guidelines for the Target Delineation of Glioblastomas, which Niazi's paper, which came up in 2016, which gave guidelines for normal tissue contouring, like for the brainstem, the chiasma, the cochlea, eyes, lacrimal gland, lens, optic nerves, and pituitary. So a lot of students do a mistake in contouring brainstem, and they don't know where is midbrain, pons, and medulla. So brainstem starts at the foramen magnum to the point where the optic tract passes lateral to the midbrain. I'll show in my slide. And this upper limit is arbitrary, but easy to identify, and it ensures consistency. And again, for consistency, the quadrigeminal plate should be included. The dose objectives are dose to the brainstem should be less than or equal to 54 gray. But so there is a differential dosing for brainstem. The outer part can tolerate up to 60 gray, but the inner part of the brainstem, we should try to keep below 54 gray. So 1 to 10 cc of the peripheral part can receive less than 59 gray. I will talk about rest of the structures in my slides. Okay. For eyes, whole of the outside of the globe should be contoured to include sclera and cornea. And the macula, it lies opposite the lens. I'll show you. So we all know about the pituitary. I will not focus much on the normal structures, but on the structures which have come new, I'll focus more on them. So pituitary is just inferior to the brain. It is connected to the hypothalamus by pituitary stalk, and by its pituitary stalk, and laterally it's the inner part of the sella turcica. We should use bone or soft tissue window, and sagittal views, it is better visualized. I'll show you in the next slide. Yeah. So if we come to the retina, this whole of this should be included as part of the globe, and this is the lacrimal gland, which is situated lateral to the eye, just in the bony area. And we have to understand that the dose is less than 30 gray, but we should, so in nasopharyngeal cases, or sometimes when you are treating the buccal mucosa tumors where you're feeding, including infratemporal fossa, then some dose goes to the lacrimal gland. So you should contour that in those structures. Now coming to retina. So retina is this the whole of this pink area that you see, and how to contour the fovea, that I'll tell you. So fovea, although it is relatively small, and it is the only area of the retina where 20/20 vision is attainable and critical for seeing fine details and colors. It is employed for accurate vision in the direction where it is pointed, and fovea comprises only 1% of retinal size, but takes over 50% of the visual cortex. Now, coming to the scalp, we should spare scalp, and at my center, we routinely do scalp sparing for females so that they don't have hair loss post radiation. So scalp sparing, hippocampal sparing, they're very, very important. Now, coming to the inner and middle ear. So how do you contour that? So first you have to see in the bone setting on CT. So you can easily identify the internal auditory canal. So cochlea is situated situated laterally and cranially of the internal auditory canal. So if you see here, and then this is the internal auditory canal, these are the mastoid air cells. Please see that you don't include the mastoid air cells in your contouring. And these are the vestibular canals, the anterior, middle, and posterior. So cochlea is only this part, and this is the internal auditory canal. Okay, so the cochlea and internal auditory canal should be individually delineated and named, and the middle ear, tympanic cavity, bony part of eustachian tube should be individually delineated and named. Now coming to temporal lobes, we do a lot of mistake in temporal lobes. I think the most common mistake is in the posterior part of the contouring. So how do you identify it? Ideally, you have to, this is the Sylvian fissure. So first you have to go up to the cranial edge of the Sylvian fissure. This forms the cranial boundary. Caudally, it is the base of the middle cranial fossa. Anteriorly, you see this is the temporal bone and this is the greater wing of sphenoid. So this is the anterior boundary. Posteriorly, it is the posterior part of the temporal lobe, and you can see the tentorium here, tentorium of cerebellum, and incisura preoccipitalis. So this is the posterior boundary. Most of the people have seen, they contour the temporal lobe and they include a part of the cerebellum or the occipital lobe, which is not the right thing to do. So laterally, there is the temporal bone, and medially, we have the cavernous sinus, the sphenoid sinus, sella turcica, and the parahippocampal gyrus. This is the parahippocampal gyrus and hippocampus. They are a part of the temporal lobes. Now coming to hypothalamus. This is also very, very important structure which we normally miss and don't contour. So this is a polygonal structure which is 2 volumes. And it is situated on each side of the third ventricle. So this is the third ventricle. So these are the 2 hypothalamus sitting on each side of the third ventricle. So superiorly, there is the anterior commissure. Inferiorly, there is the optic chiasma. So when the optic chiasma starts, we have to stop contouring of the hypothalamus. Anteriorly, there is the anterior aspect of the third ventricle. Posteriorly, these are the interpeduncular fossa. So if you see this, these are the peduncles, and posteriorly in the interpeduncular fossa. Medially, there is the third ventricle, and laterally, there are the optic white matter tracts or the internal capsule. I'll show you. This is the internal capsule. These are the white fibers. These are the internal capsules. So this hypothalamus is a very, very small structure. So you have to just first identify the third ventricle, contour on either side, trim it from the internal capsule, keep it till the posterior boundary of the third ventricle. So here you can see this looks like a U-shaped structure. Now, hippocampus, we all know it's very, very important to understand the contouring, and this is very, very important structure because RT causes the loss of neurons in the subgranular zone of the dentate gyrus. And in fact, it has been seen that if there is decreased hippocampal volume post-radiation, which normally happens 1 year post-treatment, it is associated with declined auditory attention also. And in fact, small right hippocampus volume is associated with decrease in the visuospatial memory. So we have to see individually the right hippocampus and the left hippocampus. And in fact, post-radiation, it has been seen that hippocampal volume loss is 0.13% per gray of mean dose. So 0.13% per gray of mean dose. And in GBM, the loss is even more. It is 4 millimeter cube lost per gray. So if the dose is more than 40 gray, then the loss is more. But if it is less than 10 gray, then the loss is less. For whole brain RT, we know that D max we keep at 16 to 17 gray and D mean should be 9 gray. So now hippocampal sparing RT, all of us do. And in the Gondi et al. Paper, they estimated that NTCP model EQD2 dose more than 7.3 gray to 40% of bilateral hippocampi leads to memory impairment assessed by Lisp learning delayed verbal recall. In fact, V55 gray is also very, very important because it impairs Hopkins verbal learning test. And if hippocampal dose is more than 100%, receives more than 10.9 gray, then there is 20% probability of decline. But with 60 gray, there is 50% probability of decline. So it's important that you try to save at least one hippocampus if the tumor is confined to one side. So how do we contour hippocampus? So what do you do ideally is that you first identify, I think I should have taken a larger picture, but you first identify the lateral horn, the lateral ventricles, and you first identify the temporal horns, this black area that you see. So this is the temporal horn of the lateral ventricles, and this is the parahippocampal gyrus. So this is the parahippocampal gyrus. If you see, these are the temporal horns, and this is the ambient cistern on the lateral side of the brainstem, and this D is the fimbriae. So these are the fimbriae. Okay. So so you first identify the temporal horn, and then anteromedial to that you start contouring. So if you see this, this is the temporal horn. Anteromedial to the temporal horn, you start contouring your hippocampus. So then you go up, and this is the temporal horn, and this is where the temporal horn ends, you stop your contouring. And these are the so this is the quadrigeminal cistern, and you have to stay lateral to the quadrigeminal cistern, and you don't have to include the amygdala. I'll show you in a larger picture now. So this is best appreciated on a T1 sequence. Now, posterior cerebellum. This came up as a new structure in a journal in 2018 in Radiotherapy and Oncology. So this has been seen as a new organ at risk because it also leads to memory deterioration and neurocognitive dysfunction. So cerebellum consists of two hemispheres which are divided by the vermis. So this is the anterior cerebellum. This is the posterior cerebellum. The primary fissure, it separates the anterior lobe from the posterior lobes, while the posterior lateral fissure separates the posterior lobe from the flocculonodular lobe. You can easily identify posterior cerebellum. I have been contouring posterior cerebellum for almost 1 year now for all my patients. So this is the anterior cerebellum, if you see, and this is the posterior cerebellum. This light blue is anterior cerebellum, and this is the posterior cerebellum. So this is more white as compared to gray, the posterior cerebellum. So we can see here. So Merchant et al. Has shown that in a low-grade gliomas, posterior cerebellum dose is associated with cognition. In fact, in a paper by Gay et al., they showed that head and neck patients, the patients with the lowest memory scores received a maximum dose of 36 gray on the cerebellum and low radiation doses on the whole brain and hippocampi. So if the dose is more than 36 gray, and they're also getting some low dose radiation on whole brain and hippocampus, and even head and neck patients, they can have problems in cognition and emotions. Now coming to circle of Willis, this is very, very important for pediatric patients. And we all know that if the dose to the circle of Willis is more than patients, say for meningioma or for other tumors, then the patients may develop stroke later on. And patients with medulloblastoma also, they're at increased risk of stroke later on. So how do you identify circle of Willis? You have to first understand the anatomy. So this is the middle cerebral artery. If you see here, this is the middle cerebral artery. This is easily seen on an MRI sequence, and this gives a branch that is the anterior cerebral artery. This is the internal carotid artery, which gives rise to the middle cerebral artery, and these are the anterior cerebral artery, which are connected by the anterior communicating artery. And these are the two vertebral arteries, which we can easily see. And on the pons, this is the basilar artery, which divides into the posterior cerebral artery, and the posterior communicating artery, it joins the posterior cerebral artery to the middle cerebral artery. So if you see this, you have to understand the relationship between optic chiasma and circle of Willis. So this is the optic chiasma. The middle, this is the internal carotid artery, and this is the middle cerebral artery. So this lies anterior. The anterior cerebral arteries and the anterior communicating arteries, they lie anterior to the optic chiasma. This is the pituitary stalk, and the posterior cerebral artery lies posterior. This is the basilar artery. This is the posterior cerebral artery, and this is the posterior communicating artery, which goes behind the optic chiasma. So let's see in this. So this is the right optic nerve. This is the pituitary stalk, this white dot-like structure that you see. This is easily identified on an MRI. And this is the anterior clinoid process. This is the pituitary stalk, and this is the right internal carotid artery. So this is the pituitary stalk. Anterior to the pituitary stalk, you see the chiasma. And so if you see here, this is the middle cerebral artery, which goes like this. You can see it. This is seen even on a CT scan if you learn how to see that. And these are the mammillary bodies. So this is anteriorly. So if you see this, this is the right middle cerebral artery. These are the mammillary bodies. Anterior to that lies your optic chiasma. Now, in 2021, this is a very, very recent paper which has come in. I don't know how many of you have seen this, where they have come up with a new atlas for CT and MR based contouring in neuro-oncology. So if you see this in alphabetical order, I'll go to each of these structures one by one. So this is the amygdala. If you see the brainstem, this is the brainstem. So a brainstem, midbrain is red, pons is purple, medulla oblongata is pink, and this light blue transparent is the anterior cerebellum. This is the posterior cerebellum. This is the orbitofrontal cortex. In white, these are the lateral ventricles. This is the caudate nucleus, and you see thalamus. I'll come to these structures, and this is the pineal gland. So why do we need these new organs? Because it has been seen that it's not just the hippocampus which is involved in neurocognition, but the doses that are received by amygdala, caudate nucleus, in fact, corpus callosum, fornix, orbitofrontal cortex, pineal gland, and thalamus, they all are responsible for cognitive toxicity, because thalamus is responsible for executive function and processing the speed decline. And thalamus and amygdala, they have a dose-dependent volume loss after RT. If the doses to the corpus callosum are more, then it leads to a decline in the attention and processing speed. And macula and optic tracts are responsible for visual toxicity. And the people who are doing particle therapy, they have seen that periventricular space is very, very important, and RT leads to decrease in the periventricular space. So now coming to macula. So I showed this slide before. So we all know this is the lens. So what you do is you first identify your slice where go to the center of the lens, and then you draw a perpendicular line posterior to the lens in the center. So this is the optic nerve. You go 2 millimeter laterally, use a 1 millimeter brush, and just at this you make one structure, which is the fovea. This is known as reconstructed phobia. So you have to make the right and left, and then you create an outer margin of 2 millimeter around this, and then you erase the part which is going inside the vitreous body and outside the fat. So this results in a 5 millimeter diameter disc corresponding to the macula. Fovea is at the center of the macula, and it is the most sensitive part of retina. So we have to limit the doses to the retina. Now coming to optic tracts. Normally we all contour the optic nerves and the optic chiasma, but we should know the optic tracts as well. They are best visualized on a T1 weighted MRI. So these are linear structures which extend to the posterolateral edge of the optic chiasma anteriorly and to the lateral geniculate body posteriorly. So this is the brainstem. The optic tracts just run lateral to this. So initial 10 to 15 millimeter is easier to see, but this is little tough to see. Posteriorly, it extends almost until the thalamus. And this should be stopped when the optic tract is no longer clearly visible. These are the optic radiations. Now coming to limbic system. Limbic system is very, very important because hippocampus is located in the limbic system. And what all constitutes the limbic system? This is the, you can see here, this is the cerebellum, the hippocampus, the pineal gland, the basal ganglia, cerebrum, hypothalamus, pituitary, and amygdala. So we all know hippocampus is a seahorse-shaped structure located in the medial temporal lobe. And it is an important role in consolidating information in short-term and long-term memory and spatial navigation. So this is this is what I'll go and discuss all these structures. This is the orbitofrontal cortex that you see in pink. If you see this, this is so these are the thalami on either side. This is the corpus callosum. All of us know what is corpus callosum. This is the fornix. This is the midbrain, pons, medulla, spinal cord, anterior cerebellum, posterior cerebellum, and these are the hippocampi on either side. And this is the caudate nucleus. Now coming to amygdala. So amygdala is responsible for emotional control and processing, and with hippocampus, it forms memories with the emotional context. So if there is a higher mean RT dose to the amygdala, it can lead to subjective depression symptoms at 3 months. So now, as I said earlier, genome-sparing whole brain radiation therapy is the future now. Maybe in a few years, we will be doing genome-sparing whole brain radiation. So it has been seen by diffusion tensor imaging that if there is microstructural injury within the corpus callosum interhemispheric white matter, it leads to decline in attention and processing speed. So this is the amygdala. Where the hippocampus ends, this is just sitting close to the hippocampus. All of us have been contouring hippocampus. So let's see. So this should be contoured separately. It should not be a part of the hippocampus. This is best seen on a T1 weighted MRI. This is an olive-shaped gray structure located in the anteromedial part of the temporal lobe. So this is anteriorly and medially, there is the cortex of the temporal lobe, and posteriorly and inferiorly, there is the temporal horn of the lateral ventricle. So this is the hippocampus. This is anteromedial to it. So if you can see here, this is the hippocampus, and anteromedial to it is the amygdala. So this green part is the amygdala. So in this image, you can see this area. So it leads, there is 0.1% volume loss per gray in mean dose to the amygdala. Now, corpus callosum. Corpus callosum is best seen in the sagittal images. This is the large bundle of fibers connecting the two hemispheres, and RT-induced injury is associated with decline in attention and processing. It is a C-shaped structure on the sagittal plane. So this, you can see this structure. We can identify the lateral ventricles. These are the lateral temporal. This is the lateral ventricle, and this is the genu of the corpus callosum. This is the splenium of the corpus callosum. So anteriorly, so the lateral borders are formed by the lateral borders of the lateral ventricles. Now, fornix. Fornix is also best seen on a T1 weighted MRI. This is a main output tract of the hippocampus. This is essential for memory consolidation. It's a C-shaped structure, and these are two symmetrical arc-like bundles of white matter. It connects hippocampus infra-posteriorly to the mammillary bodies anteriorly. So after leaving the hippocampus, it runs medial to the temporal horn of the lateral ventricle. So these are the lateral ventricles. It runs medial to that. And so you see here, this is the corpus callosum. This is the fornix, this area, this white area that you see. Anteriorly, it diverges, it curves behind the anterior commissure, and it forms, the contour stops at the cranial border of the mammillary bodies. So these are the two fornices. Now, thalamus. Thalamus is a relay station for sensory information, cognition, learning, memory, and flexible adaptation. Medially is the third ventricle. Laterally, it forms the posterior limb of the internal capsule. And anterior border is formed by the interventricular foramen. I'll show this thalamus in some other slide. So these are the different nuclei of the thalamus. So you can see this. You can easily identify this. This is the lateral ventricle, and these are the thalami. So if you see here in this slide, this is the thalamus. Now coming to the caudate nucleus. Caudate nucleus is responsible for motor control, cognition, and emotional processing. It is a part of the basal ganglion. So it's seen on the T1 weighted MRI sequence. It's tadpole shaped. So if you see this, it is 3 parts. This is a large anterior head. Then there is a tapering body, and then there is a tail which wraps around the thalamus. It is iso-intense to cortex on T1 weighted. So if you see these lateral ventricles, this is just posterior and lateral to it. So head forms the lateral wall of the anterior horn of the lateral ventricle. This is the lateral ventricle. This is the anterior horn. So head forms the lateral wall of the anterior horn of the lateral ventricle. Body, it lies lateral to the lateral ventricles, and it is medial to the internal capsule. So tail, it curves back anteriorly along the roof of the temporal horn. So this is the caudate nucleus. This is the thalamus. This is putamen. Okay, so this large area that you see, this is the putamen. Okay, so you can see this. I think this will be easier to understand from this slide. Now, orbitofrontal cortex. So if you see this, this is the orbitofrontal cortex. This is the cortex located at the ventral side of the frontal lobe. It has a role in memory, emotional functioning, and cognition, and in particular reward-based decision making. T1 weighted MRI is required for delineation. It is easier to identify in the coronal plane, halfway through the frontal lobe. So at this level, the orbitofrontal cortex runs between the olfactory sulcus medially and the lateral orbital sulcus laterally. So this is the, if you see this is the gyrus rectus, and whole of this area is the orbitofrontal gyrus, the insula. So this is the orbitofrontal cortex. Okay, this is the caudate nucleus. These are the thalamus, and this white structure that you see, that is the corpus callosum. Now coming to motor cortex, it is also very, very important, and we all contour the motor cortex. How do you identify the motor cortex? For this, you have to first go to the cranial most part and identify the central sulcus. This is the largest sulcus that you see, which runs from this medially. So the area anterior to it is the prefrontal cortex, which is the motor strip. So if you see this is the central sulcus. This is the prefrontal gyrus. This is the posterior frontal gyrus. So Maruyama et al. This said that if you do SRS of the corticospinal tract, and there is 5% risk of complications if the V20 gray is more than 58 millimeter cube and V25 gray is more than 21 millimeter square. So cognitive deficits have been seen by the volume of the left hippocampus receiving 10 gray and by the volume of the left precentral gyrus receiving 40 gray. So you should try to limit the dose to the motor cortex to less than 40 gray. Now these are the different lobes. This is the frontal lobe. This is the insula. This is the insula. This is the parietal lobe, the temporal lobe, and the occipital lobe. And here you can see the caudate nucleus. This is the lentiform nucleus, and this is the thalamus. So we all know that there is some cortical thinning happening posterior, post-radiation. So you can see this. This is the cortex I showed in my earlier slides. So you see some cortical thinning, and there is a global cortical thickness decrease of 0.0033 millimeter per gray. And after 36.4 gray, this thinning is much, much steeper. So, and temporal and limbic lobes, they are most sensitive to this cortical thinning. Now coming to periventricular space, we do contouring of germinomas where we have to contour the ventricles. So periventricular space has been, this is the innermost region of the periventricular space known as the subventricular zone. It constitutes a major neural stem cell niche and is associated with gliomagenesis. The two lateral ventricles along with their different parts, the frontal horn, the occipital horn, and the temporal horn, the third ventricle, including the supraoptic recess, the infundibular recess, and the suprapineal recess. The fourth ventricle, foramen of Monro, foramen of Lashka, Sylvian aqueduct, all of these constitute part of the ventricles, and you have to make 5 millimeter area around this to make the periventricular space. So in this section, you can see whole of these structures. So you have to include whole of this space when you are contouring the ventricles. Now coming to pineal gland. This is 8 millimeter in diameter and it regulates the sleep-wake cycle. It is best visualized on a T1 weighted MRI. Here you can see the hypothalamus on either side. In the midline, this is situated in the midline in the quadrigeminal cistern. It is posterior to the third ventricle. So this is the third ventricle. You see posterior to it in the, this is the pineal gland and this is the quadrigeminal cistern. Now, coming to patient preparation. So we all know that the consent of the patient is very, very important. You should ideally take a little extra time in explaining the procedure to the patient, because otherwise the patient will keep on moving and will make your life hell during treatment. Detailed history taking should be very, very important, and you should all read all the scans, the pre-operative scans, the post-operative scans, the operative notes. Read the surgical notes carefully, see where the surgeon has left the tumor. And then you have to make the patient lie down in a neutral, the head should be in the neutral position. Position should be most comfortable for the patient. Sometimes we try to make the position absolutely central and patient has a tendency to make a tilt. So if you try to make the patient central, and during treatment, the patient will have a tilt to the left side. So just try to see in what position the patient is most comfortable. The CT scan should be taken 1 to 3 millimeter slices. It should be from vertex to C3. And accurate fusion of pre-operative and post-op MRI is very, very, very important. MRI should be with contrast. If due to any reason MRI contrast is not available, then CT contrast should also be given. And please give a lot of attention to the MRI CT fusion quality near the target area specifically prior to target delineation. And as I said before, this is very, very important to utilize the coronal and sagittal reconstruction. Otherwise, you would be treating very much larger areas. So please see the sagittal and the coronal sequences as well, apart from the axial sequences. Now coming to target delineation of glioblastoma. So we all know there are two set of guidelines, the ESTRO-ACROP guidelines, which talks about the AORTC tumor volumes as per 22981, 22961, 26071, 22072. In all these trials, they have used this, the EORTC treatment volume. So EORTC treatment volume takes them only in phase 1. It treats the tumor only in phase 1 and they give 60 gray in 30 fractions. So the GTV is surgical resection cavity plus any residual enhancing tumor as seen on the post-contrast T1 weighted MRI sequences. So here the contouring is simple. You just do the surgical resection cavity and see any residual enhancing tumor. This constitutes the GTV. And CTV is GTV plus a margin of 2 centimeters. They do not take into account edema. PTV is CTV plus a margin of 3 to 5 mm. But if you see into the RTOG treatment volumes as per 0525, 0825, 093 trials, then they treat the tumors in 2 phases, phase 1 and phase 2. Phase 1 is the larger area, which is 46 gray in 23 fractions. Here the GTV1 is the surgical cavity plus any residual enhancing tumor as seen on the post-contrast T1 weighted MRI scans plus surrounding edema. So in EORTC, they do not include surrounding edema, but in RTOG, they include the surrounding edema. This is the hyperintensity on T2 or FLAIR MRI scans. To this GTV1, you give 2 centimeter margin if no surrounding edema is present. If no surrounding edema is present, then the CTV is the contrast enhancing tumor plus 2.5 centimeters. And PTV1 is CTV1 plus a margin of 3 to 5 millimeter. Phase 2 is a 14 gray post in 7 fractions. GTV2 is the surgical resection cavity plus any residual enhancing tumor, which is post-contrast T1 weighted MRI scans. CTV2 is GTV2 plus a margin of 2 centimeters. And PTV2 is CTV2 plus a margin of 3 to 5 millimeter. So definitely the volumes are more in RTOG as compared to EORTC, because here we are including the surrounding edema as well. So as per these guidelines, ESTRO guidelines, So GTV is surgical cavity plus enhancing area, and CTV2 is 2 centimeter recommended margin applied in all directions, but reduced at the anatomical barriers. Like they say for skull, 0 mm, for ventricles, 5 mm, falx 5 mm, tentorium cerebelli 5 mm, visual pathway, optic chiasm and brainstem 0 mm. These are different from the NRG guidelines. Provided the tumor is distant from the white matter tracts extending to these regions, but just ensure that in secondary GBM, there could be some non-enhancing area, maybe tumor. So you have to include hyperintensity in T2 flare in GTV. If there is a pre-existing history of a lower grade tumor, presence of IDH1 mutation, or increased cerebral blood volume ratio at DWI images, then they increase the likelihood of hyperintense signals, and which could be a component of the tumor. So here you have to include the non-enhancing areas. Now, because in RTOG, the volumes were larger, so these guidelines, they came up in 2019. So there they have given the steps how to contour. They say first to contour the GTV2. GTV2, that is the large dose volume, which is surgical cavity plus enhancing area. And then you contour GTV1, which is T2 flare. Ensure that it encompasses all of GTV2 as well. Then to this GTV, you expand it as CTV1 by including the flare plus 2 centimeter. And this, now you make it as CTV46. And then you contour and trim the anatomical barriers as falx and ventricles, etc. This becomes the treatment volume. Then to this GTV2, which is cavity plus enhancement, you create a CTV2, and this should be inside the CTV46. And this makes CTV60. And then you manually trim as per the falx and ventricles also. So if you do this trimming of falx and ventricles and from anatomical barriers, then the total brain tissue, which was initially planned, that would be reduced by 13.6%, which is very, very much significant. So this manual trimming later is very, very important. So they came up with these guidelines. So GTV1 is T2 flare hyperintensity. GTV2 is cavity plus T1 contrast enhancement. CTV46 is T2 centimeter both beyond both GTV1 and GTV2 with anatomical trimming. And CTV60 is cavity plus T1 contrast enhancement plus 2 centimeter with anatomical trimming. So in EstroEcrop, they just trimmed from the brainstem, but there they say at this NRG, they say GTV1 to include, the brainstem has to be included to the extent of the MRI abnormality involvement, GTV2 also. But if in CTV46, if it is within 2 centimeter of T2 flare, it should be included. Similarly, for CTV60, if it is the brainstem is within 2 centimeter of T1 contrast, it should be included if it anatomic contiguity, but keep it below 54 gray. If there is gross disease without margin, you can go up to 60 gray, but recommend to prescribe 2 centimeter of surrounding brainstem as CTV54, and respect the RTOG variance acceptable brainstem. To the core, you can go up surface to the core 60 gray and to the surface 64 gray. Optic chiasma, GTV1 and GTV2 include to the extent of the MRI abnormality. CTV46 within 2 centimeter of T2 flare should be included if it is an anatomic contiguity. CTV60 within 2 centimeter of T1 contrast should be included if an anatomic contiguity. Gross disease abetting the optic tissue should be treated to 60 gray. I'll show what are the common mistakes that we do in contouring. So if you see this patient, this is a patient of the right temporal GBM. So the common mistake that is done is to failure to trim the infratentorial component of post-contrast CTV. So here you see these are the variability in contours. This is the surgical cavity plus enhancing area, as you can see this. So the maximum problem was in the flare in this area and in the area in the brainstem, if you see this. So this is GTV1 flare contours. And so you can see the variability. The maximum variability was in the area close to the brainstem and in the posterior part of the cerebellum. So here this green line is the initial contour, and after anatomical ripping, this is the orange area. So here they have excluded the cerebellum, but included the area of the brainstem, which is in contiguity because of the contrast abnormality. Similarly, the optic tracts here have been included, but it has been trimmed from the ventricles. Now, a second common mistake is failure to trim the contralateral hemisphere out of the post-contrast CTV. We have to give respect to the barrier that the interhemispheric forks represents to the tumor spread. So this is, in this area, you can see a lot of variability, and the maximum problem is in this area. So this is the consensus CTV60 contour. This is the GTV1 flare contour. And if you see here, the green one is without anatomic contouring, where we have included the ventricles also. But orange here, after the ventricles have been excluded, we can spare this much area of brain. Here, this is the falx, and we have trimmed from the falx. But because there was a tumor in the corpus callosum area, as you can see, this area, this has been included, as you can see from the star. So over-aggressive trimming of the post-expansion CTV at the midline at the level of corpus callosum. This is very, very important. So many patients come up in the corpus callosum tumors where we don't target the tumor properly and we just trim across the midline. So this is a patient with this is the tumor seen on T1 contrast MRI. This is the GTV2 cavity contours. This is the CTV60. This is the consensus CTV60. This is GTV as seen on the flare. So where are the common mistakes? If you see, this is the tumor without editing, where the ventricles have been included. And here, this area is going beyond the falx. But here, because of the crossing of the tracts, we have to go beyond the falx and include this area. This area has to be included. Now, brainstem, some people do over-aggressive trimming of the post-expansion CTV from the brainstem. So if you see this patient, this is the post-contrast, this is the surgical cavity. And here, unnecessary area of the brain, of the temporal lobe has been included. So you can see the variation in contours, and you can see the variation here. Some people have just trimmed from the brainstem and not included this contrast signal on the brainstem. So if you see, this is the consensus where the brainstem has been included. This part of the temporal lobe has been excluded. You see this, the contrast enhanced area and the surgical cavity has been included, but this part has been excluded. So this is the green area which is without trimming. And here the ventricle has been excluded, but the part of the brainstem has been included. And here the cerebellum, because in this falx represents the tumor will not go to the cerebellum, so this part has been excluded. So I showed this slide before also. So there is because of lack of awareness of the anterior and posterior commissures and interthalamic adhesions. So I told you that there is crossing of the white matter tracts, and this is the corpus callosum where there is crossing in the interhemispheric spheres. This red represents, this is seen in the DW weighted images. So the patterns of failure and how do we compare the different target volume delineation. So this is a very recent paper which came up by Minity et al. So they said that the residual disease, patients which have a residual disease, they usually have a recurrence at the original site of tumor, while in cases of gross resection, the recurrence occurs along the white matter tracts. And autopsy studies have shown that more than 80% of recurrences occur within 2 to 3 centimeters of the surgical cavity. And in the autopsy studies, it has been seen that tumor cells are not demonstrable more than 3 centimeters from the main tumor in untreated lesions. The biopsy studies show that contrast enhancement consistently reflects tumor without any significant brain parenchyma. and isolated tumor cells may be infiltrated to at least the border of the T2 hyperintensity. So in this study, what they did was that they included the GTV as per the resection cavity and enhancing area on T1C as per EURTC guidelines. And they included CTV1 as GTV plus 2 centimeter. But what they did differently was that if CTV was more than 250 centimeter cube, then they to the CTV they gave 50 gray 25 fractions, and to the GTV they gave 1 centimeter margin and went up to 60 gray. And the CTV margins were reduced to 0.5 centimeter to the skull, the ventricles, and the fossa. So they defined the recurrence. How do we define the recurrences? It is a central recurrence if more than 95% of the recurrence volume was in the 95% isodose line, or the boost volume. In field, if 95% of the recurrence volume was in the high dose volume, so as per their plan, it was 50 gray, but as per RTOG, it was 46 gray. Marginal if less than 95% of the recurrence volume was outside the high dose volume, and distant is if recurrence was outside the RT field, that is beyond the 20% isodose line. So what they found was that as per this plan, this is the S-Andrea plan and RTOG plans, the most of the patients, they had central recurrence. 80% patients had central recurrence. In field recurrence was seen in roughly six patients. Marginal recurrence in around 6 patients in both, and outside recurrences are seen in 14 patients. So what they found was that if we go as per RTOG plans, then because of the edema, then the median volume that is treated is more as compared to the EURTC plans. So, and also the MGMT methylated and unmethylated patients show a different plan of recurrence. The methylated patients, they showed central infield recurrence in 64%, but distant recurrence was seen more. While in unmethylated patients, central recurrence was seen in 91% patients and distant was seen in 5.4% patients. So now coming to the dose constraints. So for children and adults, these are as per a paper from in 2014 and another paper from 2018. So Dmax in children should be less than 54 gray and less than 60 gray. This is a secondary criteria. 0.003 cc should be less than 55 gray. And cochlea, the D mean should be less than 35 gray in children. In adults, a D mean should be less than 45 gray. Try to keep less than 32 gray if possible. Hippocampus, I have talked about. A D max, D 40% should be less than 7.3 gray. For children, D max should be less than 6 gray, and volume receiving 3 gray should be less than 20%. If you are forming a PRV around the hippocampus, then D max should be less than 25.2 gray, and V20 gray should be less than 20%. Skin dose, 0.003 cc to 25 gray. A dose receiving 25 gray should be 0.003 cc. Brainstem surface, you can go up to 60 gray. Interior should be less than 54 gray, and volume receiving 60 gray should be less than 3 cc. Pituitary, D mean should be 45 gray. D max can be up to 60 gray. But for retina, D max should be less than 45 gray, and 0.003 cc should be 45 gray. Lacrimal gland, volume receiving 30 gray should be less than 50%. Try to keep D mean below 25 gray. Lens, D max less than 6 gray. Try to keep it, but till 10 gray it is acceptable. So that is all that I have to say. There's just one more concept that I wanted to emphasize, was that if you just spare the motor cortex and you don't decrease the dose to the hippocampus, then if you include both the motor cortex and the hippocampus, it allows for about 30% dose reduction, approximately 3 gray in mean dose. But if you optimize only the motor cortex, it leads to an increase in dose to the hippocampus, thalamus, and brainstem. So we should always make a combined plan with motor cortex and hippocampus for overall protection of these functional cortical areas. Thank you so much.
Thank you, Dr. Indu. It was extensive and very comprehensive. Now I have one or two questions. Now suppose it, as you said, that a part of my CTV, not even PTV, so part of my CTV is going into the brainstem. There is no way I can uh, trim it. Okay, so what would you then prescribe to the physics people to get an optimal plan without compromising the brainstem functions? So this is a common situation we will get. Part of it going into the optic structures, part of it going into the brainstem.
So it's a very, very important question. So that is why I said it's very, very important to understand the MRI properly. And you should always discuss it with your radiologist, because you might feel that brainstem is involved. But if there is contiguous involvement of the brainstem and contiguous extension of the flare hyperintensity, then you have to include the brainstem. But otherwise, of course, we cannot go beyond 60 gray. We should try to keep the brainstem dose below 54 gray. Similarly, I go back to, so similarly for the optic chiasma, optic tracts. So if there is contiguous involvement of the optic tracts, or then only you should include, otherwise you have to compromise on the optic tracts. You cannot give higher doses to the optic tracts. So there has to be a very clear discussion with the radiologist and understand, is there involvement of the optic tracts or not? If there is involvement of the optic tract, then it is different situation. Otherwise, it should not be included.
I think Dr. Kanu has raised his hand. So please come in, Dr. Kanu.
Hello.
Good morning. Good morning, Dr. Saab. Please. Hello, you are not audible.
Just wait for 2 minutes. Basically, we are converting into panelist.
Okay.
Am I audible?
Yeah, you are audible.
Yes.
So brain, addressing the brainstem, there are two concepts. If the low-grade glioma, like the IDH mutated and IDH wild, if you see the IDH wild, the patient is not going to survive long time. So getting the brainstem 60 gray, I don't mind. If there is a low-grade glioma, we are not going to go beyond for 54 gray. So in my practice, I don't worry about the brainstem. When I keep low-grade glioma, I keep it 54 gray. If it is going to the brainstem in the high-grade glioma like IDH wild, I can accept 60 gray. And the second thing, when there is not only the brainstem involvement, even there is a thalamus involvement and corpus callosum, basal ganglia involvement also, we should include the CTV inside the brainstem.
Yes.
Fine. So could I just add on to that, Dr. Kanu and Dr. Indu? So what we have also seen in our experience, okay, so as you said, what is the total dose that is going to be prescribed? Number one. So is it going to be 54 gray or is it going to be 60 gray? So if it is going to be 54 gray, then it is really not a problem for us. The CTV can include the involved areas. And if we are reasonably doubtful that there is suspicion of brainstem involvement or abutment, and the CTV needs to probably include those areas, including the basal ganglia, then, and if it is a GBM, that means we have to go to 60 gray, then another good idea would be to create a subvolume PTV. So it would be like the Matryoshka dolls, which the Russians used to sell here, like a small volume inside a bigger volume. Yeah. So within that, you could perhaps put a limiting factor of 95% of your prescribed dose. So in any case, that is the lower limit of your initial prescription, that the 100% volume should get at least 95% dose. So if you see, 95% of a 60 gray dose would be 57 to 58 gray. And as Dr. Indu has said, that 0.01 cc or 0.01% should not get more than 59 gray.
Yeah.
So it is well within, again, the tolerance limit. So where we have such a high grade tumor, where we are reasonably suspicious that the brainstem may be involved, or there may be some infiltration or abutment into the marginal portion of the brainstem, then we can include that area as a subvolume, giving it loosening our strings or increasing the tolerance to 57 to 58 gray. Good morning, sir.
Good morning. Good morning, Dr. Shaleen.
Good morning, Shalin, sir.
Good morning. Just carry on. I'm very much listening all the way through. Go on. Complete, Ashutosh.
So this has been proposed actually in a number of papers, that you can create sub PTV volumes to cater to differential doses.
So this is something which we do for nasopharynx also at times, you know. So similar concept, we also do this routinely. That's good that you raised that. Yeah.
Because both in the cranial tumors and in nasopharynx or oropharyngeal tumors with potential infiltration of base of skull, we need to cater to the dose going into the intracranium. So probably nasopharynx, what I also do is create an intermediate risk volume going up to 60 gray, and then prescribing to 97%, 95% of that.
Yeah.
So any other questions? Seeing, I think students don't have other questions.
This was too much of an information for them.
Yeah,
No,
ma'am has involved. Yeah.
Good morning, madam. Indu madam, can I ask you one question?
Yes, please.
Yeah, nice presentation. Do you follow ABTG guideline?
ABTG, no.
No, okay. There is very small margin they give, and but clinical practice we don't
that is not approved. That is not approved now. Yeah.
One more question I have regarding hippocampal sparing. Now, I agree that hippocampal sparing has shown promise, especially in young patients where expected life survival rates are high. But so far, the data that has come in for hippocampal sparing is from whole brain RT in metastatic small cell lung cancer, where the expected survival is not high. So it is mutually contradictory statements.
So actually, one patient had come to me with a metastatic small cell carcinoma, and the referring doctor had written for hippocampal sparing whole brain radiation. So to my mind, for a small cell, metastatic small cell carcinoma with limited survival, I would not compromise on hippocampus. So I would rather focus more on tumor control. So similarly, for, as Dr. Kanu also said, for low-grade gliomas, we should definitely be concerned about hippocampus sparing. And as I said, we should try to decrease the volume as much as we can. So if we can spare right side, left side, it's very, very important. But for a GBM, I may not be too much interested in sparing hippocampus at the cost of GTV, or PTV. So we have to really understand what are we treating. Are we managing a case with a low-grade glioma, or we are and IDH mutation versus IDH wild type, because IDH mutant patients are going to live longer. So that's why we need to understand all these, need to factor all these points in also before we start contouring.
Okay. One more question is, in IDH wild type, would you give 60 gray or 54 gray?
I give 60 gray.
And then a corollary to that is, would you give at 1.8 for high grade or 2 gray?
So I usually give 2 gray, but as I said, if the volumes are very much larger, if I feel that my CTV volumes and PTV volumes are very much bigger, or it is lying very close to any critical structures, then I prefer to use 1.8. Otherwise, I use 2 gray.
Can I add one thing?
Yeah.
Yeah, Dr. Kanu, please come in.
Okay. I was discussing with Dr. Jalali sir. Actually, he's telling he's preferring actually 1.8 gray. So I thought, what is the basis? He told that if you give 1.8 gray, it is a 33 fractions. So another 3 doses of temozolomide he will get.
Okay.
Not 3 doses, it will 5 doses, meaning another week.
Okay. So normally in pediatric patients, I prefer 1.8, but not in, I mean, this is my way of looking. Dr. Shaleen, any comments on this?
See, there is no doubt that dose per fraction determines late effects.
Yeah, sorry.
The difference between 1.8 gray and 2 gray is extremely unlikely to ever have a randomized trial and with large numbers to show a small difference in any of the endpoints that we're looking at. And here we are really concerned about long-term sequelae. This argument, therefore, should only be restricted to those who have a long-term outcome, which means low grades IDH mutated. It does not matter for the glioblastomas, where even currently, fewer than 10%, 8%, 5% survive 5 years, and every single patient with recurrence, even with all current therapies. I agree that intuitively, if the volumes are large, without defining what is large, you would go for 1.8, otherwise 2. Overall, for the presentation, is that okay? So that's as far as my take is concerned on this.
Sure, sir.
The second thing is, I would like to first of all compliment you for this presentation. Fantastic. And Dr. Kanhu is actually he is the new avatar here in education, and I have to compliment him for his phenomenal energy and his bandwidth and depth and contemporariness in this thing. And Dr. Kanu, we may not have met, but your contributions are amazing in so many areas.
Thank you, sir, for compliment.
Yes, thank you. But to speak to the point, Dr. Indu, fantastic presentation. My request is one. You have provided citations of some of your slides. It'll be nicer as a policy in our this thing that we provide a citation so that a person can go back to the original reference. That's just one thing. And second thing is, as a simple take-home message, I think we must communicate this, that there are, I think, 2 or 3 take-homes only. Enhancing areas are typically tumor. Flare areas, which is T2, okay. Now T2 has got water, ventricles, but flare areas are also tumor. So I think this is important. The second thing that is important to note that while the fox there, but to the associated with Callosum, this goes from left to left. You did point it out. And so therefore trimming around the fox, even though you're giving 5 millimeter, it's important that the relationship with the fox must be understood, because you may think this is fox and I'll not expand, but actually the tumor is going across to the other side. This is the other important thing. And the last important thing is that neither the brainstem nor the optic nerves are a barrier to tumor spread. And therefore, in that context, in patients with poorer prognosis, gliomas, looking at those subcritical volumes may not actually result in, it should at the very minimum not result in tumor failure or be a reason for tumor failure. And it's unlikely that in the high grades, they will last long enough. Patients will have a survival long enough to be able to actually show this. Nevertheless, these are important things that one has to be just careful about, and neither is the pituitary. Yes, the tentorium is, of course, the bone is, but none of the other neural structures. The fox is, but under the fox and through the tent and through the brainstem, the disease grows. So before trimming there, one has to think it through. And this is something, if it goes in, the rest is fine. You do single phase, you do 2 phases, the results are equivalent. You give 1.8, you give 2, results are likely to be different. And that's all I have to say. Thank you so very much.
So
It was
as you
enjoyable.
rightly said,
Although too much information for too much information for the final years, but it's wonderful nevertheless. Thank you so much.
thank you. So as you rightly said, pituitary, because hyperpituitarism can be easily managed. So we don't give too much constraint. We don't trim our CTVs or PTVs due to that.
Thank you so much, Dr. Indu ma'am, for such a brainstorming session. It was very informative. Thank you, Shalin sir, for guiding us. Thank you, Ashutosh, for moderation.
Thank you, ma'am.
And thank you all the participation here. So our next class will be on Wednesday. For this, I will share the link through mail ID. Okay, thank you so much.
Thank you so much. Thank you, Dr. Ashutosh, Dr. Surbhi, Dr. Rashi for having me here. And Dr. Kannu, he always takes out time for studies. He prepares so much. Every day he's on morning dose. I mean, my day starts with this cartoon. Thank you.
Thank you. Thank you.